Resistant hypertension, the blood pressure which is not being controlled by three mechanistically different group of antihypertensive, including one diuretics, is said to be resistant or refractory hypertension. In fact, before saying resistant, you make sure that you are not missing the pseudo resistance, that is non-compliance. Here, really truly resistant cases, you have three groups. One is the renovascular hypertension. In fact, 5 to 10% of the hypertension are renovascular, and monogenic group, next group, common group, single gene defect with tubular dysfunction, sodium absorption, chloride absorption, potassium elimination issues, and endocrine causes. Third group is the Cushing, Cones, pheochromocytoma, hyperparathyroidism, it's others. So renovascular hypertension is by far the commonest over here is the fibromuscular dysplasia, idiopathic. It's common vasculitis, your Takayasu's polyarteritis nodosa and Kawasaki disease, neurocutaneous syndrome like tuberous sclerosis, neurofibromatosis, Marfan's and others. So the Wilms tumor, neuroblastoma, they also belong to this group. Renal vein thrombosis, renal artery stenosis, and important group radiation and others causing renal artery narrowing is important. Important. And how do you diagnose these things? Ultrasound showing the kidney size discrepancy. One is smaller, other one is bigger, and then your episodic hypertension. Epigastric bruit can be found in 30% of cases, hypokalemia, and higher renin, plasma renin activity. Diagnosis these things you can do in Doppler as a screening test, but ultimately a final diagnosis is you need to do angiography. If you find it, you can do the angioplasty in the same sitting. And the TPA, if you do, you can have split function. It's less in the small kidney, more on the good kidney, normal kidney. And if the kidney is too small and then size is your function is less than 10%, it may be the source of hypertension. So go for nephrectomy over here. Monogenic cases, as the name suggests, single gene defect with hypertension. In one group, you have cortisol elevation. Suppose, for example, your congenital adrenal hyperplasia, your 21 alpha hydroxylase deficiency, 11 beta hydroxylase deficiency, they have cortisol level higher, and they have higher amount of sodium and water chloride absorption, water absorption, volume overload, and they have hypertension. And your in this group, you have apparent mineralocorticoid excess, AME, little disease, where you have excess epithelial sodium channel activation. You have your familial glucocorticoid resistance, process syndrome over here. You have jealous syndrome, mineralocorticoid receptor mutation. Williams syndrome is also belong to this group. So this group also has hypertension. They're genetic in origin, and few of this has some ambiguity of genitalia. Apart from the hypertension, some of the diseases over here has polyuria also because of the tubular involvement. And other group, the familial your familial hyperaldosteronism type 1, 2, 3, 4. Now they have higher amount of aldosterone over here, and some of them are steroid sensitive, steroid responsive, low dose dexamethasone, prednisolone, and others. So genes involved over here are CCL hybrid genes, CLCN2 genes and KCNJ1 and few more. And Martin gentlemen at times simulates with this group disorder, but a good amount of time they have other issues. Gordon syndrome, increased thyroid activity by WNK1 to 4 genes. We call it pseudo hyperparathyroid, pseudo hyperaldosteronism, the increased activation of the sodium chloride channel and the potassium secreting channel, potassium functioning channel, ROMK, is activating activity issues is there. They have hypertension. They have the benefit by adrenalectomy, and so thereby this group disorder can be identified by dint of the sodium and mostly chloride and bicarbonate, and then genetic testing, and the consequent molecular changes of the said diseases. And finally, you have endocrine disease group. They have their unique diagnostic and treatment.